Thank you so much for taking a few minutes to sit down and have a conversation about the fantastic work that you're doing. Dr. Abla, you're a hematologist oncologist at Kids Toronto. Would you mind giving us a little bit of background about your career and why you got interested in histiocytosis?
Yes, good morning. My name is Oussama Abla. I'm a pediatric oncologist at Sick Kids Hospital in Toronto, and I'm a director of the pediatric histiocytosis program at Sick Kids. I got interested in LCH initially. Since 2007, I was mentored by my colleague, Dr. Sheila Weitzman, who introduced me to the Histiocyte Society. Initially, I got involved in the LCH4 trial design with my international colleagues. And later on, I got interested into the more rare histiocytic disorders, for which we created an international registry, of which I'm the current PI right now. Yeah.
Thank you so much. You are doing such amazing work for the community, and I know that the international rare registry that you have is a wonderful resource and an opportunity for us to learn so much. And you also participate in a wide range of activities. So I know you participated in the American Society of Hematology conference this year, we call ASH, and you did so with also had a publication that was titled Langerhans cell histiocytosis, Promises and Caveats of Targeted Therapies in High Risk and CNS or Central Nervous System Disease. And this was a fantastic publication. I'm sure it had a lot of great benefit at ASH. I'd love to learn a little bit more about the publication and how you participated in ASH, either through this or other activities.
Sure. So in March of last year, I was asked to give a speak at the ASH meeting regarding Langerhans cell histiocytosis, the wider clinical presentations in children and in adults, and to write a manuscript as well, which I gladly accepted. But immediately after that, I was also asked to be an abstract reviewer for the session on monocytes and disorders of histiocytes, for which there were many histiocytosis abstracts. Some of them very interesting, but many are also quite interesting. And as a consequence, I was asked to be a moderator of that session on the abstracts regarding histiocytosis and other granulocyte disorders. But when I had offered this opportunity, they gave me a title that was so general, and I really wanted to focus on the two most challenging aspects of LCH in children, and that is relapsed and refractory disease and central nervous system LCH. So I took that opportunity and I actually used an example, one of my patients that I had many years ago who presented with diabetes insipidus and multisystem disease. I just took the course of that patient and what happened to him in the course of many years after. As you may know, Langerhans cell histiocytosis is a rare myeloid neoplasm where you have the infiltration of these cells in different tissues. And we know today that this disease is driven by mutation of the MAPK pathway, mostly a BRAF V600E mutation, but also other mutational oncogenes. And I really wanted to focus on relapse refractory disease, and when do we use targeted therapies, and what is the background from using those types of therapies. But also, it helped me actually because I read more and more about the topic, and I learned a lot, even with this publication. There is a lot of actually ways that people can benefit from this, because we know today that also for central nervous system disease, the neurodegenerative form, which has a devastating course. These patients, they respond to targeted therapies, but more recently, a group from Sweden showed that you can check the spinal fluid for biomarkers, and one of those biomarkers, called the neurofilament light, actually can predict patients who are prone to developing CNS neurodegeneration, and you can monitor these patients' spinal fluid for this protein while they are on the inhibitors, and that can actually determine that they are responding also clinically. So that's the background.
Wow, that is really interesting and very beneficial. I know years ago, we weren't quite sure how the CNS disease developed. And so to be able to actually monitor and to kind of predict and see what's happening is really impactful. So how will this benefit the future? How will this impact the way that you and your colleagues treat LCH or care for patients?
So I think we have to be very careful in really considering that with targeted therapies, you have the optimal cure. Because we know that these medications, the BRAF inhibitors and MEK inhibitors, we know that they are quite effective, and they are less toxic than chemotherapy. And they are given by mouth, and they guarantee, a better quality of life for the patients. Very few, if any, hospital admissions, no or little infections. But they do have caveats, so people have to consider those caveats really. And the most common one is that the fact that they do have some toxicities, especially to the skin, in children and in adults. And in adults, they can cause, actually, although rarely, skin cancers. We haven't seen that yet in children. But there are also problems with toxicity to the heart, to the eyes, mildly to the liver and to the kidneys. You have to be cognizant of these side effects, and they have to be monitored. So that's the first caveat. The second one is that we don't know when to stop these medications. We don't know the optimal duration, and we know that both in children and in adults, once you stop these medications, 75% at least of patients' disease comes back. So that's a problem, and that's because these medications, they don't eradicate the clone, they don't kill the cells, but they put them to sleep, basically, as opposed to chemotherapy, where they kill the cells, actually, and they may kill the clone. So that's another caveat. The other caveat is their limited penetration to the brain. We know that they penetrate a little bit, but not that much. So therefore, for CNS or central nervous system disease, we don't know how effective they can be. So that's why now there's focus in the pharma world about introducing new medications that have the ability to penetrate better into the CNS. One of those medications is the DAY101, or tovorafenib, which is being studied now in the Children's Oncology Group trial, ANHL 2121, where they are studying this medication as single agent orally for the high-risk patients, for patients with refractory and relapsed disease. So this medication has a better CNS penetration, has less toxicity to the skin, to the heart, and to the eyes. And it's being studied for the first time in LCH in children. There are other medications that can also penetrate better into the CNS. One of them is called mirdametinib. There is a current trial out of Cincinnati for upfront patients, children with LCH as well. But the other caveat also is the fact that these medications have a high price tag, so they're quite expensive. And countries with limited resources may not be able to afford this. And even in North America or in Europe, patients who don't have insurance will not be able to afford this. We're talking about the cost between $2,000 US dollars a month up to $30,000 a month for an adult who's on cobimetinib. So they're quite expensive. So we have to be really careful about considering that these medications are the absolute cure. They're not. We're hoping to study them better in the future, perhaps combining them with chemotherapy. We may be able to arrive at a point where you can stop these medications in a subgroup of patients, because when you combine inhibitor and chemo, we might be able to prevent relapses. But we need more studies, larger studies, and with a longer follow-up period.
That speaks very much to the importance of, and a lot of people ask, how can I help? And participating in research is one way to help, because these studies really do give us so much more information, have led us to where we are. And thank you for sharing the caveats as well as the promises. I know targeted therapy is a very exciting promise, and very grateful for all the amazing work that's going into understanding how they can become even better potential treatments and cures, hopefully one day, to be able to use them and improve the quality of life, but also to see histiocytosis gone from the body, from the individual impacted. Is there anything else you'd like to share, any about the publication or just any of the work that you're doing?
Yes. So again, in the publication, I do present two algorithms. One for the treatment of CNS disease, just to give the reader an opportunity to decide when to start inhibitor versus when to give chemotherapy. So there are two types of CNS disease: the tumoral one, which is more easily treatable with chemotherapy, and the neurodegenerative one, which is the most difficult one. But if you have someone with only radiographic MRI pictures, you can just monitor them and wait until they develop symptoms. Whereas those with clinical symptoms, there is actually an algorithm on what to do for those patients. There's another algorithm also for the reader to help them decide when to give chemotherapy and when to consider BRAF or MEK inhibitors for relapse disease, for relapse and refractory patients. But in conclusion, what I would like to say is that although we are in much better shape today than when we were 10 or 15 years ago, before the era of inhibitors, when we only had chemotherapy, salvage, myelosuppressive, toxic drugs that sometimes led to mortality, unfortunately, and also during the era of bone marrow transplant for LCH, which is today is almost abandoned because of these new drugs. As I mentioned, these drugs are not yet curative, so we need to study them more. We need more studies, but we also need a few more things. We need to update our disease response criteria in 2024 for pediatric LCH. We need to introduce the new modalities like whole body MRI and PET scan, and understand what does a complete remission mean, what does a partial remission mean. And we may actually need to learn more and study more the impact of molecular studies, the peripheral blood test PCR for the BRAF mutation. You can monitor that, and sometimes some studies have correlated that with disease activity, but others did not find it in the sense that sometimes you can still have the blood positive, but the patient is doing well clinically. So we don't know what that means. So we need to study more about that. But most importantly, we need more closer international collaboration between the Histiocytosis Society, the European Echo Group, the NACHO Group, the Children's Oncology Group. We need to enroll patients on studies to better understand the biology of the disease and to better understand the best treatment going forward for really the high-risk patients, as I mentioned, the CNS one and the refractory relapse patients. But we also need more support from histiocytosis associations from the North America and Europe and other parts of the world, and from pharma, from drug companies. We need the drug companies to adopt this orphan disease and put more funding into research, into understanding the biology of the disease, and also in testing new drugs, new targeted therapies. one of the things that I also found by being a moderator at the ASH meeting is that there's a new role of perhaps HDAC3, which in the pathogenesis of LCH. So, and this is a marker on the surface of the cells. So perhaps in the future, new drugs like HDAC inhibitors or even other new therapies, like checkpoint inhibitors with or without MEK inhibitors might be effective. So we need more studies. We need more knowledge of new targets for this disease.
Thank you, and I know that you're driving a lot of this work, and it's really, I agree. I think we're at a point where we can turn and open the doors a little wider to see what all else we can utilize. As you mentioned, these therapies are wonderful. They've been very impactful and have saved a lot of lives. And they're not curative, and there's still so much more we can learn. So we're at a very exciting point, and also the opportunities to collaborate and to continue to come closer together to make these studies possible, to enroll patients, will lead us ever further. And I'm excited to look back 5-10 years from now and see everything that we know. I feel as though the pace with which we're learning is faster and faster, and it's pretty incredible to watch, and appreciate your passion and commitment to making that happen.